post-operative patient. So this is another picture of a JP drain, Jackson Pratt drain, and that is compressed. Okay. So we've talked about our interventions. If you have a patient who has a lot of drainage, they may, or you may, put on what we call Montgomery straps. It's a type of dressing that you can use if you have frequent dressing change needs and you're not ripping tape off of your patient 6 and 7 times a day. Okay? What it is tape that is put across the patient's abdomen. Usually you see this with abdominal dressings. And they meet. It meets and you lace them together, either like shoelaces or they can be individual ties. Okay? So you untie it, you peel back the gauze that's over it, and then here's your dressing up under it. Okay? So you're not removing tape. You're just untying, removing the dressing that's under it, changing the dressing, and then retying it. Folding the clean gauze back over it and retying it. That's called Montgomery straps. Okay. If you have a person who's really got some skin issues, but yet they need a big bulky dressing, this would be the way to go. So if you see Montgomery straps, that's what we're talking about. This is working. Good. Okay. So complications. Of course, we can always have the risk of infection. What did I say a wound looks like if it's getting infected? It's red, hot, a lot of swelling, and it's painful. It hurts. Okay? Yeah. And it's not just a tenderness, okay? It hurts. Now, don't go in there poking around, too much. Yeah, you're liable to get hurt. But it is very tender and painful for your patient. With a wound infection, the important thing is that we identify it early. Okay, your patient will probably be put on systemic antibiotics. A lot of times, if there's a real big risk for infection, the physician or the surgeon irrigated the wound with an antibiotic solution in surgery before they closed them up. That may have happened. Or you may have to irrigate the wound, okay, with sterile antibiotic solution. You may have to pack the wound, especially if it's an open, really big draining, nasty wound. You may have to do that as well. Okay. Your patient always has a risk for wound dehiscence, which is actually opening up of the wound, and evisceration, which is when the organs actually spill out through the opening. Okay. This is your folks who have healing issues, your diabetics, immunocompromised people. Of course, your elderly people, your obese people. Okay? So we always need to make sure we're aware of that risk. A lot of times your dehiscence occurs when your patient is coughing or straining, vomiting, those type of things, especially if they're not splinting their incision. Your biggest risk for your wound to open up is about 5 to 10 days post-op. Your patient pretty much can tell you when something happens. Okay? It doesn't have to get to the evisceration stage for them to know, oops, something popped. That's usually the way they'll tell you. Is it popped or something came loose in there? Grit your teeth and smile and help your patient back to bed. and then take a look at that wound. Okay. I have seen patients, something popped, and they're holding it. They're holding bowel. If I'm holding my bowel, it's an emergency. It's an emergency. Get me to the bed, okay? This is an emergency when you have a dehiscence and an evisceration, okay? Put your patient back to bed, and somebody must stay with the patient while everybody else is running around crazily to get the things that you need. The physician needs to be notified. We need to get some vital signs. We put our patients supine in the bed with their knees up. Okay, remember how we talked about how bringing the knees up releases some of the tension on the abdominal wall? You want to do that in this case as well. All right. We're going to take sterile towels and put over the wound, and we're going to moisten those towels with sterile saline. You do not ever, ever, ever want to push anything back in there. That's going to be your gut instinct, no pun intended, but it's going to be you're going to want to do that, but don't. Put your patient to bed. Bend their knees, okay? Have somebody bring you sterile towels and sterile normal saline, and it's a lot and some sterile gloves, and it's a lot easier to open up the towels, put it on the patient, and then pour the saline on top, rather than try to open up your thing, pour your saline, and then try to drip it all the way across to the patient. Okay, just put it across, pour it on there, saturate those towels. Okay, we've got to keep those organs moist, pliable. Okay, and then you're getting your patient ready to go back to surgery. That's where they're headed. Okay, so don't be giving them nothing to drink while they're waiting on the doctor to come in. Okay, they're headed to surgery. Hold them in PO. Try to keep the patient calm. And one of the best ways that you can do that is for you yourself to be calm. Okay. Put your nurse face on and do what you have to do to take care of your patient. At the end of it, you can go, oh my God, did you see that? Okay, you can do that later. But take care of your patient. You have a chart in your book, chart 18.5, that talks about the care of a patient that has eviscerated. Look at that. Okay. So again, someone, and preferably a licensed person, needs to stay with that patient at all times. You don't want the patient playing around with it, okay? Making sure that, they can have blood pressure drop. They can have some problems. So get their vital signs, hold them in PO, get that covered, and then just have a seat until the physician gets there, and then things will move again to get the patient headed to surgery. All right. Of course, post-operatively, we're going to have issues with pain and discomfort. We expect that, but we have to manage it. Okay? We usually do that with pharmacologic meds, drugs, good things, drugs. Okay? Most of your patients will come out of OR with IV, narcotics, and opioids ordered. Some of them may have patient care analgesia or PCA. Y'all know what that is, right, and how that works. We talked about that the other day, right? Okay. Your patient may have an epidural cath, which is a catheter that's in the epidural space that anesthesia will bolus them every now and then excuse me, with the analgesia. But post-operatively, you're probably going to have patients on morphine or Dilaudid. Stadol and Toradol are good ones as well. But PCAs, usually we're looking at morphine with the PCAs. Your patient in PACU is really not going to be getting an awful lot of pain medication. Okay? Because when you give pain medication, it can mask some of the problems that they may have with anesthesia. Okay? It doesn't say that they never give pain medicine, but if they do, it's very, very small doses. Okay? They don't give 10 of morphine and then just wait to see if they need to give some more. They may give one, see how the patient reacts, and then they may give another. It's small increments in the PACU. And then they reassess them every 5 to 10 minutes and see do they need to adjust that. But you as the post-op nurse are going to do a lot of assessment frequently on your patients for their pain control. The drugs are out there. They're ordered. Have them for your patients. Give them to your patients. Giving your patients pain medication around the clock works better than giving it to them PRN. So a lot of times your physicians will order it that way. Okay, keeping them comfortable. We don't want it to get to a level of 10 and then try to control that. Okay? Some of your patients are very iffy and don't want pain medicine because they don't like the way it feels. So that's the way we have to do education to make sure that they understand. Let's control it now before it gets so bad. And then sometimes they just won't. Okay, so all you can do is educate them. How do you know somebody's in pain? They're grimacing, they're moaning, they're guarding the area, they're, That's with respiratory stress. They're restless, okay? What kind of changes do you see in their vital signs? Everything speeds up, right? So if I have increased blood pressure, increased pulse, increased respiration, and I got a restless patient that's sweaty, sometimes they get kind of sweaty. Have we talked about any other issues that the patient has those same things? Shock, initially, early shock. Respiratory problems, okay? Some of your cardiovascular problems, some of your GI problems. So you as the nurse, when you notice this, you have to say, okay, what is it? You have to assess your patient. Is it pain? Is it hypovolemia? Are they getting into respiratory distress? Okay. You got to do your assessment and converse with your patient if you can. Okay. We always want our patients to rate their pain before we give it and after we give medication. Again, think about what you're going to do with your patient, all right, and medicate them before you do it if you need to. If your patient is going to get up and move around, they're going to do a little bit better if they're medicated. Okay? Now, we don't want to medicate them so much they're a fall risk, okay? But sometimes just getting out of bed is a chore. If you're going to do a pretty involved dressing change, okay? If you are going to take out a drain, that Jackson Pratt drain, that thing's about that long. And the first time I took one of those out, I didn't know it was that long. I thought it was like a Penrose, about that long. So when I took it out, I hurt that patient tremendously because it doesn't just pull it out. So I think about that poor fella every time I take one out because he came off of the bed. So you're sedated now if I got to pull one of them things on you. Okay, so think about that before you do it. Okay, it is painful. So tell your patient, we're going to take the tube out today. I really would like to give you some pain medicine before we do that. You know, give them a dose of their pain medicine, and then say, I'll come back in about 20 minutes or whatever your time frame is. Don't do it 2 because it ain't working in 2. I'll come back in about 15, 20 minutes, and then we'll take your tube out. Okay? They appreciate that. Trust me. Well, you didn't have me as a nurse. So, yeah. It hurts, doesn't it? It didn't hurt. Well, this fellow come off the bed, so. Good. Well, I hurt this guy. So, I mean, I did. I felt bad. I felt bad because I did. I don't like to hurt him if I can help it. Sometimes you have to, though, but you know that. Okay, so think about pain medicine before you do anything to them. Usually your patient is going to be at their peak post-operative pain on post-op day 2. Have you heard people say, oh, second day's the worst, or third day's the worst? That's right. Anesthesia is gone. They are starting to feel a little more alert. They're moving around a little bit better and more, so they're sore. Is that a word? Okay. So post-op day 2 or 3, and it's usually post-op day 2, is their worst. We do keep our patients on opioids, usually IV, the first couple of days, and then we start moving them toward PO meds. We do want to watch for those signs and symptoms that we're overdoing it, okay? How do we know I'm oversedating our patients? They have respiratory depression. Huh? They can't speak. They're incoherent. Yep. What else? Their blood pressure will drop. Absolutely. So when we overdo the narcotics and the opioids, what is the drug of choice to reverse that? Narcan. When we overdo the Versed and the Valium and the benzodiazepines, what's that reversal agent? Do you know? Oh, no, don't ask me the generic. Thank you, Romazicon. Who said that? Good deal. Thank you. Romazicon. So if you're doing moderate sedation and you give your patient Versed, and we've overdone it a little bit, they're a little too sedated and we need to reverse it, we're going to give those people Romazicon. Romazicon. Mm-hmm. For Versed, Valium, the benzodiazepines, we use Romazicon. The narcotics and the opioids, we use Narcan. So be very cognizant of your patient's pain. There's no need in patients to hurt. Okay, we expect them to be sore and all, but you know, in the post-op period, your patient is not going to become addicted to pain medication. Give it to them because they're happy and you're happy. Okay? Sometimes we try to withhold stuff like that because we think the patient doesn't need it. Just give it. If your patient is stable enough and they're rating their pain, they know what their pain is. We may not agree with it, but they know what their pain is. We document it, we give it, and your patient is happy. and you can move on to the next task that you have to do. Okay? There are some non-pharmacologic treatments out there, sometimes just helping to change a position, warming your patient up. A patient who is shivering can have pain post-op. Sometimes just sitting and holding their hand, rubbing their back, patting their hand. Okay, touch works wonders. And sometimes just letting the family in will calm your patient down. And it doesn't necessarily have to be a kid either. Okay, just seeing a friendly face. Well, I hope your face is friendly, but a face that they recognize. All right. Questions about pain? Assess it, treat it. Okay. Gerontologic considerations. We've talked about everything is affected if you're elderly. Okay. Just know that when you're giving medications to your elderly people, much easier to put them in respiratory depression, easier for them to become toxic on those drugs, changes to their mental status, and then their pain. They tend to underreport pain, so let's be their advocate and ask them, are you sure you don't want something for pain, or can I do anything to make you more comfortable? The younger people will take anything you give them. Okay, because they know there's no need in hurting. I'll take anything. There's no need in hurting. That's what meds are for. Okay? All right. So, let's get this patient to the house. Okay? Planning for discharge. When does the patient's discharge planning start? From the minute we decide the patient's got to be in the hospital. Okay? The minute the patient you're right, when the doctor says we need surgery, all right, we start planning for getting that patient back home. Okay? So with discharge and follow up, we've already talked to our patient about some of the things that they're doing post-op, but now let's talk about what they're going to be doing when they get to the house. Okay? Or if they're going to an alternate site. All right? They need to know how to take care of their wound, what kind of dressing care and site care they need. If they have a drain, how to empty it, how to measure it. They need to understand the medications that they're going home on, how to take it, what it's for. And they are given a list of medications. They should remember we're going to do this whole med reconciliation thing where they're going to be given a list of their their home medicines, what to continue, what to add. Okay, they get that list and it goes with them. They are told about their activity level. They can't go upstairs, or they can't drive for so many weeks. They don't need to lift anything over so many pounds. When they can resume sexual activity. Those type of things. Activity is usually increased slowly. Depends on the surgery. Sometimes they go home, they have no restrictions. Okay? Dietary. What kind of restrictions do they have on dietary? Most of the time, folks with a wound, unless they don't have any kind of contraindications, we want them to have high protein, high calorie, vitamin C. Those are the things that help with wound healing. Okay? And we can't send our diabetics home on high calories and that kind of thing. Most of your surgeons and your hospitals have standing discharge orders for specific physicians, and surgeries. So Dr. Naylor's discharge colon resection orders, they know what they are. They have a list of them. They go over them with the patient. The patient goes to the house. Dr. Noel's colon discharge orders may be a little bit different, but that his patients get those. Okay, so a lot of standing orders when you're talking about these surgeries. Your patients need to know what symptoms to look for and when they need to report them. Things such as fever. You need to contact your doctor if you have a fever over 102. We expect the patient to have a little bit of a temp post-op, okay, but it should not be 102. Some doctors don't worry until it starts to get over 101 that there may be an infection going on. So you need to contact the physician if the drainage from your drain is ever more than 100 milliliters a day, or whatever it's set at. So what to report and when to report it. Where and when to follow up with the physician. And then you need to make sure that you set time aside to answer any questions or concerns that the patient has. Make sure that they understand the things that you said. We also need to address their pain control. What to do about their pain. If you're sending a patient home on antibiotics, they need to know what about taking them. When do you take it with food, and you take them all. Take them all. Sometimes your patients are sent home with home health, and home health will come out and do the dressing changes and the care and stuff like that. But still go over these things with your patient, okay, so that they can handle it until home health comes by for the first visit. All right. So, last slide. Oh, yay! So we've talked about preoperative nursing focus, intraoperative nursing focus. Tell me some postoperative nursing diagnoses that you can think of. Risk for infection. What else? Risk for poor wound healing. Absolutely. What else? Activity intolerance. That's a good one. I didn't hear that one, but that's so true. Activity intolerance. What else? Altered skin integrity. If they have a wound, it's already altered, so it's not a risk anymore, right? What else? Acute pain. What else? Knowledge deficit on how to care for themselves, right? What else? Fluid volume issues, overload or deficit, could be either one, absolutely. It could be psychosocial issues, absolutely. Do you think a woman who's had a mastectomy is going to have some psychosocial issues? You betcha. You betcha. Altered body image, absolutely. Constipation related to pain medicine or what? Altered, just the altered GI function. I'm sure there's a nursing term for that. It's not coming. But you're right. Constipation is certainly from all the pain medicine, the anesthesia, and just from the slowing down of GI function. Right? Nausea, correct. How about respiratory-wise? What kind of issues? Impaired breathing, altered gas exchange, okay, altered tissue perfusion, all that kind of business. So basically, everything, right? How about nutrition-wise? Any issues with nutrition? Altered nutrition less than, because we're probably not overfeeding these people. Right? We're probably keeping them NPO or they're on Jello a day or two. Remember, we gradually progress their diet. Okay? If they can't tolerate a diet or they've had a big old GI surgery, they may be, how do we feed them? Not a tube. What kind of liquid? They've had a GI surgery and I'm holding them NPO. How am I going to feed them? TPN, thank you. TPN. They may have intravenous nutrition. Do you remember that? Yeah, sure. People go home with TPN. They sure do. It's an infection control issue, but yeah, they have IV companies that come and manage that business. Sure. All right, good. So when you're looking at post-op issues, okay, just know that a lot of your body systems are at risk for being altered, okay, just simply because they've had the surgery. And what do you do for that? Any questions, thoughts, or comments? Keep it nice. Are you good?